Sure. Well, thank you very much for the invitation, and thank you for those who are joining us. It's actually a great pleasure for me to be able to talk about something which has been a passion for a long time, about developing new therapies for kidney disease. I'm an endocrinologist, so one of my interests has really focused around diabetic kidney disease, but the therapy that we're going to talk about is really applicable to the vast majority of kidney disease, maybe with the exception of polycystic kidney disease, but all others would be amenable to this form of therapy, we hope. And the study that we are progressing is called the DIRECT trial, which stands for Diabetic Renal Disease Cell Therapy Trial, and I'm just one of several investigators. My co-investigator, Kevin Burns from Ottawa, is on the line as well. But as you can see written there, we have several principal investigators, and hopefully other groups will be able to help us to recruit participants in the study as well. And what I'd like to do in this brief overview is to look at how we have focused on what are the causes of kidney disease at a tissue level, and to use that as a way to explore the therapeutic approach, the way of treating kidney disease that we hope to evolve, and talk about the move that we've made from animal studies to the setting where we are now, which is discussing with Health Canada about how to get the study underway in patients. So if we take, for example, someone who I might see in the diabetes clinic, a 68-year-old woman with diabetic kidney disease, she's on every therapy that we have that we think protects her kidney and her heart as well, and her eGFR is 44, so she's lost a significant amount of kidney function, but still a lot in reserve, and that was her results back in 2014. That's not a real photo of her, but we look at what can happen over the next few years, and that is that progressive loss of kidney function, so that in 2 or 3 years' time, there's really no choice except to go on dialysis or hopefully get a transplant. And our aim is to try and stop that downslope, to try and arrest the progression of kidney disease where it is and stop it going any further. Now, not much has happened really in kidney disease for a long time, and it's really lagged behind heart disease in terms of new therapies. And here we're looking at the complications of diabetes, and there's been dramatic reductions in heart attacks, acute myocardial infarction, huge reductions in stroke, but ESRD, so end-stage kidney disease, really not much has happened over 20, 25 years or so. So it's really time that I think that we need to change the way that we approach the kidney disease and try and halt its progression. And we know that of the causes of kidney disease, diabetes is quite up there. 38%, according to the Kidney Foundation of Canada, 38% of all new cases of kidney failure are due to diabetes. And so that's one of the reasons why we focused on diabetic kidney disease. But as you'll see, and as I'll show, that we think this is, the therapy should really be more broadly applicable. This is what the kidney looks like under the microscope when a biopsy is done. And the features I'll point out to you as firstly is that there is a loss of the capillaries, those very small blood vessels that supply the tissue with oxygen and nutrients, and they get lost. The capillaries die off, and so instead of having a kidney that's being nourished with oxygen and nutrients, it's oxygen and nutrient deprived, and that causes the functioning tissue of the kidney to die off and be replaced by scar tissue. This biopsy is from a patient with diabetic kidney disease, but exactly the same process occurs in most other forms of kidney disease. This is now the biopsy of a patient with IgA nephropathy and loss of GFR, and the effects are similar. There is fibrosis and loss of functioning kidney tissue, and the underlying reason, once again, is loss of the capillaries, those small vessels that nourish the kidney tissue. And if we look at the relationship now between the number of capillaries on the horizontal axis versus the serum creatinine, so the inverse of GFR, the fewer capillaries there are, the worse the kidney is going to function. A very strong relationship in diabetes, and on this slide, a very strong relationship between non-diabetic kidney disease. This is a range that you can see on the right of many different types of non-diabetic kidney disease, IgA nephropathy, focal glomerulosclerosis, amyloid disease, all showing the same pattern, that when there is loss of the capillaries, then the kidney is more damaged and functions poorly. And the third in the series is just to show you this is not a single study, but other studies show exactly the same, where the loss of the capillaries is the major determinant of whether that kidney is going to continue to function or go on to end stage. So in those patients who at their biopsy had more than 10% of the tissue had capillaries, did very well, whereas those that had less than 7% did very badly. And what that means is that there's not that much of a gap between having enough capillaries to sustain the kidney tissue and having an insufficient supply that would cause the kidney to undergo further development and progression of disease. So in this slide, we're looking at what happens. Now, on the bottom, those round objects are the cells that line the blood vessels. And because of pressure on them and inflammation and high glucose and other injurious factors, there's an excess death of those endothelial cells, we call them, the lining cells of the capillary. They undergo apoptosis, which is just a scientific name for cell death. Now, that happens normally at a very low rate. It's accelerated in the kidney in the presence of kidney disease, and that's what causes those blood vessels, the capillaries, to die off and drop out. Now, we used to think that those cells, when they're lost, can be repaired by neighboring cells, and that probably happens. The neighboring cells fill in the gaps, but that's not the major way that blood vessels are repaired. They're not repaired by this direct mechanism. They're repaired by another way, which is that stem-like cells come out of the bone marrow. They circulate in the circulatory system, and they home to where those lining cells have been lost. So they know where to go, and they come in and they secrete factors that allow the cells of the lining of those blood vessels to be repaired. So these are pro-reparative circulating endothelial progenitor cells, or EPCs, we call them for short. And so having enough of those cells to repair damaged vessels is very important. Embryologically, there is a known relationship between those cells that line blood vessels and the bone marrow that's shown here in the embryo. So we have an understanding of where they come from and why they're there. And we can identify these EPCs by the markers that they have on their cell surface. So we have a fair idea of where they come from how to identify them, and what they do. Now, one of the things that happens in diabetes is that there is a reduction in the number of these EPCs, these cells that come from bone marrow and repair the lining cells of blood vessels. They're reduced by about 50% in diabetes, according to this study, which is just one of many. And in non-diabetic kidney disease, the same thing happens. So on the left in the gray is healthy controls, and on the right is the white bar is patients with chronic kidney disease. And the number of those EPCs is halved compared with the healthy controls. So not only is there accelerated loss of those lining cells of the blood vessels, but there's a defect in the ability to repair them. And together, those two factors are responsible, we believe, for the loss of the capillaries, the worsening of kidney oxygenation, and progression of disease. So I'm an endocrinologist, and one of the ways that we think is that when we find a disease, we try to replace what's missing. So on the top is the discovery of insulin, severe life-threatening disease transformed by insulin. On the bottom is a woman with hypothyroidism, with thyroid disease, thyroid's not working well. We replace the thyroid hormone that's missing with thyroid hormone tablets. And that's the way that we kind of think. And with that background, we wondered, well, could the same thing work? Could we regrow blood vessels if these EPCs are missing? So we started off many years ago, about 10, 11 years ago, looking at patients with angina, with chest pain from coronary artery disease, and did a very small study where we collected the EPCs, these bone marrow-derived cells, from blood in a process called apheresis. We then gave the cells back to patients with angina, infusing them directly into the coronary artery of those patients, and found a really dramatic effect that we were able to generate new blood vessels. So here is a coronary angiogram, and the more of those sort of black spidery-like things you can see, the more blood vessels there are. And we were able to show that there were more vessels, more blood vessels after the EPC treatment in this study. And what I think was even more impressive was that the patients who started off with an average of about 10 to 15 episodes of angina per week were angina-free by 1 month and remained so at 12 months. So very encouraging data for the heart. And in other studies by other groups that have done similar work, showing that in a 2-year follow-up, that the likelihood of death or repeat heart attack or hospitalization for heart failure was reduced by about 70%. So it looked like a very favorable treatment for blood vessel regeneration and improvement in disease. But as many of you know, that my interest is really in the kidney disease area, and so we had to go back to animals to see whether we can get some beneficial effects in animal models of kidney disease. And animal models are very tricky because you want to have an animal model where what you find in the animal you think is going to be transferable to patients with the disease of interest. So we chose an animal model that we think closely resembles progressive kidney disease of all forms, a condition called the 5-6 nephrectomized rat. And what it develops is the same pattern as most forms of human kidney disease, loss of capillaries and scar tissue formation. So on the top here in the sort of brownish picture, on the left, we're looking at A is a brown stain for capillaries. So this is the glomerulus on the left on A, And panel B, there's the glomerulus you can see on the right-hand corner, and then the other parts are the brown staining of the capillaries in other parts of the kidney. If you look at C, it shows in a diseased kidney with this model that there's a major loss of blood vessels both in the glomerulus in C and in other areas in D. And on the right in panel B, we're looking at the blue area is scar tissue formation. So there's scarred kidneys with no blood vessels or very few blood vessels, resembling very much those very early slides that I showed you about human kidney biopsy. So we think we've got a good model. We can extract those cells, those EPCs, from the bone marrow of the animals, and they look very much like human EPCs. And so this was the trial that we designed, which was to give these EPCs in this rat model that resembles human kidney disease and give the cells both intravenously and intra-arterially. Now, we did that the usual way people had been giving these EPCs or stem cells was to inject them directly into the organ that is injured. We thought that because they're designed to repair blood vessels and normally come from the bone marrow, they should be able to find their own way to the site that they need to repair. And we thought also that injecting them intravenously would be much easier for a clinical trial, and that was the process that we did. We looked at both so we could compare. Here is a fluorescent microangiogram, an FMA. What we're doing here is we've injected fluorescent beads into the blood vessels of the kidney, and the blood vessels light up with this fluorescent green. And this is a normal glomerulus from a normal kidney. If we look now at the top, we're looking at a normal kidney on the top left. The green outlines the blood vessels in the glomerulus, and the bottom left outlines the blood vessels in parts outside of the glomerulus. So it's a nice bright green network. In the disease model, what you see is a loss of that green network. The blood vessels have dropped out, both in the glomerulus and in the other areas, what we call the tubulointerstitium. And then on the far right, subtotal nephrectomy plus EPCs, you can see that the blood vessels have been restored. So proof that we think we can achieve what we thought we could in this animal model. And when we look at the markers of kidney disease, when we compare our injection of just salty solution of saline, there is progressive increase in the protein in the urine over an 8-week period, whereas those animals that receive the EPCs have virtually no protein in their urine. That's one marker. Most importantly is that we see about a 30% improvement in GFR. So a patient who has, for instance, might have a GFR of 30 after the treatment could theoretically have a GFR of around 40. And that would be a major achievement if one could keep that level of GFR without it progressing. Blood pressure was not affected, and that's important because anything that reduces blood pressure in an animal model will also help save the kidney. So what we're seeing here is that the effect of the cells was independent of a blood pressure effect. Importantly, for when we're thinking about moving ahead to the clinical study, is that the cells were as effective when they were given intravenously versus directly into the artery that supplies the kidney. So that's, for us, a major breakthrough, because it means that we can now give the cells simply by an intravenous infusion rather than having to do a minor surgical procedure and try and give them directly into the artery that supplies the kidney. We're not the only group that have been doing this sort of study. There are others in the world, and here we're looking at the effects of the different types of ways of giving EPCs and how well they work. And the conclusion is that EPCs work well, a single injection is enough, healthy and pre-treated EPCs work, and an intravenous approach works well. And what that means is that doing this, moving from the animal study to a human study, if we think that they're translatable or that we can generalize, they're all good signs about how to do it. So at that stage, we're sort of stuck with saying, well, rats with kidney disease can now be happy, there's a potential treatment, but we really need to move that into the human setting. So three issues come up for this. One is the source of the cells, trying to get funds, and then designing the trial. We're very fortunate, I think, here in Canada that we have two stem cell facilities, one in Ottawa and one in Toronto, that are very keen to participate and help with these sort of studies. Duncan Stewart in Ottawa and Kim Connolly at St. Michael's Hospital in Toronto. So the study involves collecting these cells by a process that's not that dissimilar from dialysis, in that the blood is taken, the cells are taken out, and the rest of the cells are then given back in the process. The cells are then cultured up, and we're at a stage where the cells are from one's own body, so they're not transplanted in the conventional way, and that allows us, I think, to move to an early phase clinical trial, first to show safety and then show that the cells actually produce something. Now, this is not an inexpensive therapy by any means. In the long term, however, it would be far, far cheaper than dialysis even for 1 year. And so it's a kind of a long-term investment, but getting the funds to do the research is not easy. And so we're particularly grateful for the CanSolve CKD network for allowing us to be able to move to this, to try this therapy. Now, the trial design, as I've mentioned, we have a number of senior investigators from around the country that are going to be helping us. We want to have a trial that has a clinically meaningful outcome, both in safety and effectiveness. We would like to target those patients who are at very high risk of progressing to end-stage kidney disease, so targeting those patients whose eGFRs are less than 45, and targeting particularly those patients whose disease seems to be progressing rapidly. And one of the things that we need to do is we need to be confident with the precision of the GFR measurement. So we'll be doing something called measured GFR with iohexol infusion, which is a chemical that is excreted by the kidney that is a very precise measure of kidney function. And what we aim to be able to find is a 25% reduction in the rate of decline of GFR with rapid progressors using measured GFR. And if we do that, our estimate is that we will require 51 patients in the trial to be able to study that. And for the trial to be successful, we need to study those patients whose disease is progressing moderately quickly, so losing more than 3 mils per minute of GFR per year. And what we'd like to do is to study those patients in a year without giving them any treatment to make sure we're getting only those whose illness is progressing more rapidly. using the iohexol measurement will give us more accuracy. The study design is to have that observation period and then do a safety study and then to move on to an efficacy or effectiveness study. And the way that it will go is that we'll give randomized subjects to 20 million EPCs or just vehicle, do a safety analysis that Health Canada wants us to do. If that is thought to be safe by our Data Safety Monitoring Board, we'll then go to a higher dose to 80 million cells. And then after that, if it still turns out to be safe and we have no suspicion that it won't be, we're very confident that it will be, we would then move to do some effectiveness. One of the things that we'll have to do on the way, though, is not only to monitor for the usual side effects, but also to look at the eyes, because we want to make sure that these cells, when they go to the eye, don't cause any problems in diabetes, where eye disease is often manifest. And then after we're sure that they're safe, subjects, patients in the trial who are enrolled will be randomized to either a placebo, to 20 million cells, or 80 million cells. And I'd like to be able to tell you this is the first study to be doing that. There's actually one small study that's smaller than the study that we published, study that we plan is being published, showing a benefit that there is a reduction in the rate of decline of GFR with another type of stem-like cell called MSCs, and another trial is underway in the UK. So we're not the only ones who are thinking about this. The cell type that we'll be using is slightly different, however, ours is probably going to be more easily generalizable to other institutions rather than being confined to a single center. And at the moment, we're preparing to go back to Health Canada. We went last week, and they've asked us to do some more studies with very much the safety in their mind. We're pretty confident that we'll be able to meet their demands and then progress the study sometime, hopefully early next year. And I'll stop there. I think that's my last slide. Thank you, everybody, for your attention.
Thank you, Richard. That was excellent. Kevin, do you want to add anything to that before we open it up for questions?
I just want to say that that was a fantastic presentation, Richard. Thank you. And I don't know if you want to comment at this point about the issue of the fact that the cells are will be derived from diabetic patients, and some of the challenges with using those cells, and the fact that they're not as effective as cells from patients without diabetes, and what strategies we might have to take on to enhance their efficacy.
Thanks very much for pointing that out, Kevin. As you've alluded to, that conditions like chronic kidney disease or diabetes, even separate from chronic kidney disease, affects all of the cells in the body, and so these cells, these EPCs, don't work optimally as well. One of the ways to overcome them is by giving a lot of them, which is part of the plan. But the other thing is to think about how can we make them function better. And what we're in a fortunate position is that Duncan Stewart, who I showed the photo of earlier, who runs the EPC facility in Ottawa, has derived a mechanism for improving the function of those EPCs in the disease setting. And so we're fortunate in that we think we're going to be able to reverse the damage of the cells by using these sort of super cells that contain a gene that will make them more active and hopefully resolve the issues that are associated with kidney damage and with diabetes. So that's very much in
Okay,
I will.
I guess, sorry, the other question in the original protocol, Richard might want to say we had included the open label phase, and I guess right now, because of, I guess, funding limitations, we may not be possible to do that with the existing budget, but at least we can complete the safety and efficacy component during that year of follow-up, right?
That's right. It's a very important issue. We strove to be able to design a trial where if the study was positive, we would be able to then continue and offer those patients who had originally received just a placebo the active cell therapy. The problem that we've encountered is that if we harvested those patients' cells in the beginning and then froze them down and then thawed them later, they wouldn't work as well. And so what that would mean would be a second round of harvesting cells on patients, and that's the expensive part. And the compromise would be that if we didn't, if we needed to include that, we wouldn't have enough, wouldn't be able to study enough patients to actually prove that it works or doesn't work. What I do think, however, is that if this study works and shows a benefit, that we do not anticipate much difficulty in getting more funds to do a larger study and to include those patients as the first cab off the rank to be able to join that study. This would be a really dramatic sea change in the approach to kidney disease. So I'm confident that they won't miss out.
Yep.
Richard, maybe I'll ask a question before we open it up. You've mentioned that these cells go to damaged areas of the blood vessels and that you were thinking that you would inject them intravenously. You also talked about the eye, and you talked about safety. Like, what are the potential, from a safety perspective, what are the potential downsides? Where might they go, or what have other researchers observed using these? And is it, I mean, could this have a benefit for the eye? Because the disease is also a blood vessel disease in the eye. Could they have a benefit in other areas of the body that, you know, other, obviously,
yeah,
angina you mentioned is a big issue for people with diabetes as well.
No, you're absolutely right. One of the things about diabetes is that it's a systemic disease, and so the changes that we see in the kidney with blood vessels dropping out is going to be seen in most other organs as well. The eye is a matter of timing. What happens in eye disease in diabetes is that there is that capillary dropout, and then the cells become atrophy, and there's ischemia, there's lack of oxygen delivery to the retina of the eye, and that causes damage in and leaky blood vessels that obscure vision. And in a very small proportion of patients, maybe about 2 to 3% or so, their eye responds by producing its own abnormal blood vessels that bleed easily, and that's called proliferative diabetic retinopathy, as you know. It's uncommon. It's treated very early by laser treatment by ophthalmologists and by injections of anti-VEGF therapy. It's called directly into the eye. So it's uncommon. So to recap, there is a long period of loss of blood vessels that could benefit from these EPCs, and that would be terrific. And then in some people, they may have an adverse reaction. If they're producing these abnormal leaky blood vessels themselves, then adding EPCs may be detrimental. I think overall it's going to be beneficial. We're going to make sure that we don't recruit those patients who look like they're prone to that proliferation, but just to be safe, it's probably better to examine the eyes more regularly than would be done under normal circumstances, just to be extra cautious in the trial setting.
Makes sense. Other questions? I have several, but can you tell me, I guess I don't, I could be considered at the level of a patient in terms of my understanding of stem cells. I've forgotten a lot in 25 years. Can you tell me a bit about, so this study in the UK you were saying is using different types of stem cells, and that other researchers are considering other stem cells which may not be as, may not provide as many options moving forward. Can you just remind me about the differences between these different types of stem cells?
Mm-hmm, certainly. So the whole area in terms of what we call the cells is controversial, and we probably don't refer to them as stem cells as much, because a stem cell should be able to generate all forms of body tissue and organs, and these cells don't. The bone marrow is the main source of these, what I guess we now probably call more progenitor cells rather than stem cells, and even that word is debated. But let's just call them endothelial progenitor cells. So there are two main forms that come out of the bone marrow. There's the EPCs that we've been talking about today, and then there are MSCs, which are mesenchymal stromal cells, and they're very different in terms of their origin, but they seem to be able to both function in terms of being able to produce these capillaries, and allow for repair of blood vessels. The MSCs, these mesenchymal stromal cells, are mostly derived from other subjects. So the EPCs are autologous. They're taken from one's own circulation and grown up in culture and given back. The MSCs that the other groups are using are usually from a single or a few healthy donors, and then they're given to the patients with the kidney disease. And so the issues about having allogeneic cells, so cells from a different person, and what that means in the long term are less clear than using these these autologous cells. As you can imagine, one of the issues about the MSCs is that they produce immune tolerance, and is that going to be a good long-term prospect for patients to have these cells that generate immune tolerance in their body for prolonged periods of time? And so I would say they're less tried and true than the EPCs are. They have maybe greater potential, but also potential perhaps more for adverse effects that are way down the track that we don't know about. We know for EPCs that they've been trialed for the last maybe 15 years or so, with virtually no adverse events, provided they're done in a clinical trial setting and not in a stem cell clinic that's just set themselves up without approval from regulatory agencies. So that's in a nutshell.
That was very helpful. You have a great way of making this understandable. Other questions?
We've had a couple come in online here, so I'll just read a couple of these.
Thank you, Gary.
First one from Dwight, who's one of our patient partners on the call today. So first of all, thank you for a great presentation. He was diagnosed with interstitial nephritis due to a drug interaction. Could this treatment help him if his eGFR starts falling?
My initial thought would be yes, because the pathology is really very similar, no matter what. One wouldn't know until one tries it. But I would say yes. I would have every hope that all kidney disease, with the exception of polycystic kidney disease, should respond to this treatment.
Great. Okay. And the second part of that question is, if the trial is successful, how long do you think it would take to get the treatment to market?
So that would be, you know, the usual way would be that a single study like ours, if it were positive, is what's called a phase 2 study. So it finds the right dose and finds evidence of a positive result. For it to become widespread, it would need to move to the next phase, which is phase 3, where instead of looking at change in GFR, the regulatory authorities like Health Canada and the FDA would want to see evidence that it had a consistent effect like that in a larger population, and that it also reduced the rate of development of end-stage kidney disease and requirements for dialysis. And that would take probably another 3 to 5 years or so if everything went smoothly. So that's probably, we're looking at, I guess, 6 to 7 years if everything goes perfectly well, which often doesn't happen.
Okay, yeah. Thanks very much for the answer. I had another question from Selena, who's asking if you could please describe the role of the CanSolve CKD patient partners in the study.
Yeah, absolutely. So we've had very helpful advice about how to promote the study and how to engage patients to be involved and help with the lay summary and consent form. And we're I think at a stage where we'll need to get a lot more advice once we've got all of the science and approval with Health Canada under our belts. So really that's going to be the next step is assistance with help in recruitment once we've done that. But it's actually Kevin Burns has done a lot more work with the patient group than I have, so I'll hand it over to him.
Right. So as Richard was saying, we've had 3 patient partners involved in this study so far. That's Gwen Harrington, Mary Bocage, and Dwight Sparks, who have been formally came to the meeting, and Dwight attended the meeting that was at the CSN meeting this year. And we've asked them to comment on some of the protocols we've created, as well as the draft consent forms, and that was extremely helpful. I've also had the opportunity to present this protocol to our Patient Family Advisory Committee here in Ottawa. So this is a committee that meets monthly to review sort of clinical protocols in our nephrology program. And there's been a great deal of interest in the study, but at the moment, I can't say we've had a patient come forward to want to become engaged in the project, but we're still exploring that opportunity for patients here in Ottawa. And I think it's Richard's correct in saying that, you know, I think there'll be much better opportunity to get involved once we have the Health Canada issues solved out, because we have to go back and do some preclinical studies before that happens. But there are tremendous, really tremendous opportunities, let's put it that way, for this study and a lot of interest.
Great. Thank you.
Thanks, Kevin. Richard, can you still hear me? It's Braden.
Yeah.
Okay, sorry, I'm on my cell phone. To that end, clearly patients don't want access to something that's harmful or has safety implications, and they would clearly want this to be tested rigorously. But when HIV came about, or we started learning about it in the 80s, there was huge pressure to increase the rate of this testing was made available for those types of agents. Is there a role for patient partners to write a letter to Health Canada or to put in a patient impact statement about, the impact of the downsides of kidney failure and being on dialysis?
That's a great idea. One of the things I think of is that, from a pure economic point of view, even it makes so much more sense to have a prevention treatment as well. I think that would be a great help from patient partners to be able to do that, to free up some government funding specifically for this process. The data I think are compelling about the expenditure and the burden psychosocially as well as to the economy that CKD and end-stage kidney disease entails. I think that would be extraordinarily helpful. A great idea.
To my recollection, in addition to putting pressure on governments, they put pressure on the FDA, our version of Health Canada, to fast-track studies. So perhaps in that way, the patient partners could be of assistance as well.
I agree. I agree very much.
Helen, is that something we can take offline and assist with?
Certainly.
Graham, any last questions?
No, that's all we've got for now. If anyone has any other questions, please feel free to put them in the chat window or raise your hand if you have an audio connection.
Okay, well, knowing that it's almost 8 o'clock for Kevin and Richard and some other people undoubtedly on the phone, maybe we'll wrap it up at that point. When we figure out what we're doing in terms of patient partner letters, we may want to send out a letter to the partners reminding them to watch the webinar and considering providing some input. Thank you all.
Thank you very much.
Thank you.
Thank you.